Hey everyone, we're here this morning with I'm here with Priscilla and Joe DeRisi, who runs the Biohub, which is a center for research that works on a whole lot of different types of diseases in basic science. But Joe DeRisi specifically is an infectious disease expert, and we wanted to talk and do a little fireside chat and answer some questions about the coronavirus and how we're responding to it across the different organizations that we run here. Facebook, the Chan Zuckerberg Initiative, our philanthropy, and the Biohub, which we helped start a few years back. I want to start off just by saying that I know that this has been a really hard period for a lot of people around the world. I know in the last few weeks, the urgency of the issue has really picked up in the United States. But even before that, since early January of this year, and in some cases late December, a lot of people in East Asia, in China and Singapore, Japan, South Korea, now most recently as well, a number of places in Europe, especially Italy and northern Italy, have really been feeling the pain of the coronavirus. And as a running a company that has offices in all of these places and running services where people use our products in all these places, this is something that we've been focused on for a while. And I just want to say up front that we're thinking of everyone who not only is afraid of what is happening and wants to understand it, which is why we want to answer questions today, but people who have their friends affected, people whose businesses are affected. This is obviously a big deal for people across the world, and we want to do everything that we can to help be a part of the response to this. On the Facebook side, I'll talk about that briefly, but then today I think we'll spend most of the time talking about the science and health work that we're doing as part of the Chan Zuckerberg Initiative. But in Facebook, the big priorities have been making sure that people can get access to accurate and good information and stay connected to the people that they care about. In terms of making sure that people have accurate information, we've formed partnerships with organizations like the WHO, the World Health Organization, in order to make sure that when people search for coronavirus information, that they are getting accurate information. We've basically, as part of these partnerships, given the WHO unlimited ad credits to run messaging for whatever they think is important for public health messaging across our services. And we're going to continue working with them and other organizations, health organizations like that around the world to make sure that we can get accurate information out. Equally important is just making sure that misinformation doesn't spread. So we're partnering with them to make sure that for things that they've debunked, that we're taking them off the platform. We're making sure that our recommendation systems aren't surfacing that kind of stuff. This is a really high priority for us, and we're taking that very seriously as well. And then, they're also just on a day-to-day basis, making sure that people can stay connected with the people that they care about is increasingly important, especially as social distancing. The idea that part of the way to slow down the spread of the virus is just to make sure that you're not congregating with groups of 50 or 100 people all at once, where you don't know if they've been exposed to it before. A lot of people are working from home, working in smaller areas, are either quarantining or distancing themselves. And in times like that, people can get very lonely. And we see that the use of the internet and social services and products like the ones that we provide in areas that are heavily affected by this, the usage of these kind of services increased dramatically during times of a crisis like this, because that's when people really want to know that they can be connected to the people they care about and execute this kind of social distancing in a way where you don't feel isolated from the people around you. So we're very focused on just making sure that we can continue to provide those services reliably and stably for people, as they're very important during times like this. And I'm sure I'll do more sessions like this where we'll talk specifically about the work that we're doing on the Facebook side, but today we want to focus more on the work that we're doing through our philanthropy and through science and some of the public health work that we're doing. So, Priscilla, I don't know if you want to chime in and give a little bit of an overview of the Chan Zuckerberg Initiative science efforts overall before Joe, maybe then you can give an overview of what you're seeing with the coronavirus specifically, and some of the steps that we're taking to address this.
Yeah, so at the Chan Zuckerberg Initiative, our science program really thinks about how do we improve, support basic science, build tools for scientists, build tools for folks on the front lines of basic science to be able to better do their job. And so we do grant making, we build software, we give it away for free, and all in the aims of how do we actually make scientists better so that they can be part of advancing the frontiers of knowledge so that we can cure, prevent, or manage all disease by the end of the century. And I feel so lucky to be sitting next to Joe, who was one of the basic science lecturers during my medical training that inspired me. Like in medical school, I saw so much, medical school and residency, I saw so often the power of sitting with a patient and caring for a patient, but oftentimes that we just didn't know enough and that we needed to push the frontiers to really be taking care of our patients and giving families, patients, medical providers hope that we can do better. And, more than a decade ago now, I remember sitting in a lecture and saying like, whoa, that guy's really smart. That's cool stuff.
I remember after that lecture, you came home.
I came home and told you. And it was sort of I thought it was really awesome. I told Mark about it, and I didn't really think much about it again for a while because one gets busy in medical training. But I feel so lucky that we get to work alongside Joe to continue building that mission of really being able to invest in that hope. And there's never been a more timely moment to have your expertise. Joe played a role in helping us figuring out SARS when that outbreak happened about a decade ago now.
2 decades.
2 decades ago?
2003.
Oh, God. It's a long time ago. Well, depends on how you count. And now I feel inspired, energized to be able to work alongside and support your work. There's a lot of places where our work comes together, the Biohub, IDSeek, but I'm going to let you talk about, rewind back if you want to talk a little bit about your learnings in 2003 and what you're doing now.
Yeah, sure. And why don't you just also give an overview of what just a basic overview of kind of what we know about the coronavirus that's spread at this point as well.
Yeah, absolutely. Well, first of all, thank you, Mark and Priscilla, for having me here. This is a really great opportunity to speak to you and your audience as well. Just to give a little bit of an overview, the coronavirus outbreak, also called COVID-19 or SARS-CoV-2, which is the name of the virus, is a very related virus to the original SARS that was the cause of the outbreak in 2003. We can talk about that more in a minute. It's an RNA virus. It's in a different family than other RNA viruses like influenza, but it's very similar. And many of the symptoms that it causes are very similar to the flu, but it is not the flu. This virus probably originated from the best evidence that we have in a bat, most likely. Now, whether there was an intermediate between the bat and the human is unknown. But there was a zoonotic transfer. That means a transfer from an animal to a human of this virus, and now it has been transmitting from person to person. The WHO has declared this a pandemic as of yesterday. It has affected basically most countries and a continuing larger number of. Now more than ever that we need to come together as a research community across both public and private enterprises to bring our A game and collaborate and communicate across this. And that's what the Biohub was actually founded to do. It's a partnership between UC Berkeley, Stanford, and UCSF, together with my co-president, Steve Quake. We are reaching across all these different organizations and trying to bring our A game and also connect everybody else to bring their top game to this fight.
It's all about collaboration, so we see a little piece of it, and how do we actually come together and come together in a meaningful way at a time like this.
So do you want to give a little bit of context on where are we currently with the spread of this and the outbreak, and to some degree, what should people kind of expect over the next month or so?
Well, there's no crystal ball, obviously, but you can make some predictions based on what we've seen in other countries, and that gives us some guidelines of how we should act. So there's probably a little over 126,000 confirmed infections. In the United States, it's somewhere over 1,300 and growing. We know that in certain areas, like in Italy and in the Middle East, it really has taken a foothold and expanded quite faster than probably everybody expected. Europe seems to be now a hotspot of growth for this. And with the introduction across the United States, especially on the West Coast here, where we recently had the cruise ship come in and dock and so on, there is a concern that the situation could get out of control, much as it was in Italy. And that's why we need to do preparedness planning and understand what are going to be the needs in our clinics, what are going to be the needs for clinical testing and research testing in order to try to put up the biggest fight that we can. It's not about containment anymore. It used to be that we talked a lot about containment, that we can hold it at bay. I don't think that's a realistic assumption anymore, and that we're more in the mode of how do we prevent a surge against the healthcare system? How do we make sure that we can slow roll this, or a lot of people call it flattening the curve, to prevent a huge spike of infections hitting the health system all at once? Because there's only a certain number of beds, there's only a certain number of physicians like yourself and others that can actually deal with this on the front lines, and that capacity will be stretched to its limit with a huge spike.
Yeah, so this I think is a really important point for people to understand and internalize, because when you hear in the news wall to wall, okay, there's this virus that's spreading, a lot of people are getting it, some people are dying, people naturally worry about what does this mean for me and my family. But a lot of the responses that are being put in place are largely being done to make sure the overall system doesn't get overwhelmed and that we can minimize the spike. So maybe you could talk a little bit in more detail about that. So on an individual basis, who is at risk and kind of who might worry about this more than others, and for whom is it maybe not as big of a risk? And then for the public health system overall, what does it mean to spread this out over a longer period of time so that way it doesn't spike and overwhelm the healthcare system? What happens if the healthcare system gets overwhelmed? Why is that bad? What can we hope to prevent if we do a good job of this?
Sure. Well, let's start with your latter point first. What happens when a healthcare is overwhelmed? I think we're learning some of those lessons from northern Italy right now. When a healthcare system becomes overwhelmed, there has to be there's a necessary breakdown in the usual care process. So individuals that would normally get a certain level of care may be triaged to a lower level of care if the beds aren't available, if the physicians aren't available, if equipment isn't available, and so on. So it's there's a certain amount of capacity, and that capacity has to absorb those incoming patients. Furthermore, patients with other kinds of diseases, heart attacks, strokes, other kinds of conditions, may also be impacted by a healthcare system that is stretched to its limits. So flattening the curve is incredibly important at this moment. It's about slowing down this infection, which is where social distancing and many of the other kind of public health preventative measures that we will talk about and have talked about come into play.
Can you say more about what those things are?
Well, I mean, one example is just what the tech companies are doing at this point. I mean, basically, the move that Facebook and Google and others have had to basically strongly encourage, in some cases require people to work from home, that is all about slowing down the spread, right? It's not that our employees or citizens across the world in general won't be exposed to this at some point. I think given the spread of this, the likelihood that you as an individual will come into contact with someone over the next few years who has this is fairly high. And I think the data, although I'm not the health expert on this, is that the vast majority of people who come into contact with people, even if they contract it, will experience extremely mild symptoms. But part of the reason why Facebook took the early step to we canceled our developer conference F8 this year. That was a pretty big step, and it's a big event for us, and why we encouraged people around the world to work from home is just because if we can slow down the spread of this and take down that initial spike and smooth this out over a longer period of time, that by itself will have a bigger impact on the health system's ability to treat people, both for this and for other things that people just get sick from on a day-to-day basis. So now I know one of the questions that people are asking is, okay, well, all right, so the tech companies have closed down or encourage people to work from home. It's not just tech companies, it's more broad at this point as well. But at what point do you open back up? And I don't think people know the exact answer to that, but I don't think that the answer is going to be when every case of this is gone, right? It's not that a case around the office means that the office needs to be shut down. This is largely a public health move to slow down the overall spread, not necessarily an individual health move, because most of the individuals that these companies would be exposed to this probably would not be at significant risk, unless I'm getting that wrong.
No, you're absolutely right. And I think we also have to be extremely cognizant of who are the vulnerable populations too. So what the epidemiology out of China and other places is telling us quite clearly is that this disease differentially affects older individuals more severely. And actually, maybe the silver lining in all this is children seem to be relatively asymptomatic or very minor symptoms. Yeah, and I think that's a remarkable feature. There are other viral diseases that have this feature where they only have mild symptoms in children but are more severe in adults, chickenpox for one. But this seems to be a feature of this virus. So the vulnerable populations are the ones that we really should keep in mind. Are older individuals, especially with comorbidities, whether they have a heart condition, already have lung damage, or perhaps have diabetes or something else. These are individuals that will be more at risk than the general population. And that is something when we think about our activities and our social gatherings and our social distancing, those individuals in particular must be kept at the forefront.
So do you have are there any hypotheses that you've heard for why this doesn't seem to be affecting children under the age of 9 as much?
Well, I don't have any clear hypotheses for you. You know, as I mentioned,
or other viruses.
There are other viruses.
What are the other analogs for this?
So there are other RNA viruses that have this feature. Hand, foot, and mouth disease tends to be mild in children, and if you're adult, if you tend to get it, it's not a pleasant disease to have. Chickenpox, as we mentioned, it's not well understood from an immunological point of view, like why a child might have more mild symptoms. We know that as people grow older, their immune systems begin to fail. They become more restricted in their ability to respond to different pathogens, and may be over-exuberant in an inflammatory response as you get older. Those are hypotheses that are out there, but for this coronavirus, we just don't know. There's not enough information.
It's interesting because I mean, typical for viruses, you would expect that the most vulnerable populations are both young children and older people. So I think this is one of the questions that I've heard a lot is what makes it so that certain diseases affect young people a lot and others don't?
Yeah, it's a fascinating question. I mean, certainly a major respiratory pathogen that doesn't get a lot of press, but is a huge reason for emergency room visits for children, is respiratory syncytial virus. Yeah. Also a respiratory disease virus. Really affects children very hard and also the elderly, but spares that middle fraction. Each virus has its different biology and there's different immune responses. These are things that are going to become the focus of research in the future, I'm sure of it.
Yeah. And maybe say a bit more about another set of questions that I've heard a lot are different people obviously have various health issues already. Which types of health issues seem to be correlated with bad outcomes for this versus which ones are fine or don't make you any worse off if you were to have an issue here? And obviously all this is not fully understood yet, but just from the things that you've seen so far.
Yeah. As you mentioned, we don't really have that full catalog in play yet. However, what is fairly obvious is anything that affects your lung function, any kind of lung damage may predispose you, or smoking or pollution, heart issues. Because as a person with infected lungs will have to necessarily make the rest of their organs work harder, and if you have a deficit in some other part of your system, that can come into play as your system has to work harder to get oxygen.
Yeah.
We have a question. It's a good question.
About social distancing.
If we're supposed to be practicing social distancing, why are we sitting so close together? So social distancing is not just physical proximity. It's really about being incredibly mindful about if you have any symptoms, what your risk factors, what your exposure history is, and what your own risk factors are. As far as I know, none of us have any specific exposure history. We all feel well today.
Yes.
And we are...
I mean, we live together.
We live together, so we're generally... we've been this close together in the past 24 hours. But also being mindful about what you're exposed to, what your risk factors are, washing your hands, not sharing any like cups or materials, and also making sure that we are very thoughtful about when we gather. This seems like an important thing to do, to come together and actually have this conversation. But in general, we are minimizing unnecessary exposure.
That's right. Social distancing is 1,000 different human behaviors that we can modify, and we can all do our part. When I came here, I didn't shake anybody's hand.
Nope.
I went to the bathroom and immediately washed my hands. I have my own cup. You have yours. All these little
As opposed
things
to
matter.
normally you'd share a cup.
Elbow bumps instead of handshakes.
Yes. Yeah, we're good at the elbow bumps.
Yeah.
Yeah. Maybe we wouldn't have shared cups anyway. But,
There are general social norms.
there are social norms that we adhere to, and we can expand those with 1,000 little human behaviors. And all these things will have an effect on actually decreasing the transmissibility and spread of this virus.
Yeah.
Okay, so I want to make sure we have some time to get through the specific work that we're doing at the Biohub and in our science work, the Chen Zuckerberg Initiative more broadly. But first, I'm curious to hear, so from the work that you did on SARS in 2003, what's similar here, what's different in terms of how we have to fight this, that's informing some of the strategies, and then we'll get into some of the work that we're doing.
And did science get better? Like, how did the scientific community change and the culture change between those two outbreaks?
Yeah, that's a great question. So in early 2003, I became aware of a novel respiratory infection that was beginning to emerging in Asia. There were reports in Hong Kong and Vietnam and other places. And that became what we now know as SARS. And this SARS virus is a very close relative to that original SARS virus. But I got to tell you, 2003 to today, there is so much that different. Science is so much faster, so much more accurate, and we have so many more tools at our disposal. It's really a tremendous difference. I was fortunate to be able to play a part in assisting with the discovery of the SARS coronavirus originally. We and others were able to participate in that. It was really a group effort that came across the WHO, CDC, and international partners to figure out what this virus was. But at that time, we didn't have tools like next generation sequencing or other things. We had to do things very manually, very slowly. And now, with the advent of a lot of new biotechnology, molecular biology tools, we can go at warp speed. And we're seeing that now in the aspects of open science and like the bioarchive. So these are preprint servers where information and papers can get out to the community before peer review. They still have to go through the normal peer review and all the scientific norms. But to accelerate communication, these servers now exist where they didn't exist in 2003. And we are able to look at reports out of China, out of Europe, out of thousands of researchers coming together in ways that just weren't possible in 2003. It's really mind-blowing.
So let's talk about testing for a bit. I mean, one of the big questions that people have, I think, both individually for themselves, and we can maybe talk about that and the importance there, but just at a population level to understand what is going on, the ability to do more testing. Different countries have had different capacities. South Korea has done a lot more testing. And one of the projects that we've had is trying to dramatically increase the Bay Area around here, the capacity to do more testing. We recently announced we're investing alongside UCSF and Stanford. We formed this COVID task force. We're investing to 4x the UCSF's capacity for doing testing. What are we doing? What is so important about this, and what should people understand about why the testing is relevant to understand the spread of this and what is happening overall?
Absolutely. So, as you can imagine, testing is critically important to understand the epidemiology. How much of the virus is out there? Who's carrying that virus? And what is the likely to be the load on the healthcare system? Knowing the number of infections directly informs you about how many patients you can expect to see. So, diagnostic testing is a fundamental tool that we must have. I think that what South Korea has done, what China has done, and other countries is really an excellent model. And frankly, we're playing a bit of catch up here in the United States to bring all of our testing capacity online. In fact, the United States has tremendous testing capacity, but it's been a little bit slow to get going, but the acceleration is really taking off right now. At the Biohub, we're examining where there are deficits and where there are surpluses. Stanford was able to bring on their testing to a very high capacity pretty early on, and we are able to connect different partners with that capacity. We're talking with our Department of Public Health partners, DPHs, as well as CDC and local health officials. In the case of UCSF, bringing their capacity up larger was really a matter of bringing in new clinical diagnostic machines. Their staff are working really hard to get those validated, which every machine and every test needs to be validated when it arrives. That's happening now, and all these different efforts will hopefully bring clinical testing, up to a level that's going to be able to ascertain the real load in the population. I'm also personally very interested to understand how our research universities and genome centers and biotechnology companies can leverage research testing to help with the epidemiological work as well. As you know, research testing is different than clinical testing. Only a clinical test can be used to make decisions. But we stand and sit upon a tremendous research capacity. So we're brainstorming with partners across the field right now to understand how to do that. And I think the University of Washington has actually been a model in this area.
Yeah, interesting. So you've also been a part of inventing and creating some novel diagnostic tests. So the work that we're doing across CZI and the Biohub, and now also in partnership with the Gates Foundation on this tool IDSeq, infectious disease sequencing, is one of the more amazing pieces of technology that I've heard about recently. And I'm curious to hear you. You can give a summary of how it's being used. But just for, and I posted about this yesterday on my page. Wired wrote a really interesting piece about this as well. If you want to check this out, if you're watching the stream, but the basic technology here that I find really fascinating is there was this insight. It was about a decade ago, the cell-free DNA hypothesis, right? It's where basically people. What's up?
Sure, I'll jump in.
Yeah, and it's a research tool, not a diagnostic tool.
So, around 2007, 2008, the real big quantum shift in molecular biology was the advent of so-called next-generation sequencing. And what that allows us to do is sequence lots of bits of DNA and RNA all at one time instead of just one piece at a time. Instead of sequencing one little bit of SARS at a time, you could sequence millions of pieces at a time. Now, what this enables us to do is sort of unbiased metagenomic sequencing. What does that really mean? That means if there's a patient or a sick animal or anything else, we could take a sample from that and in a very unbiased way, with no prior hypothesis, sequence all the material, all the genetic material in that organism and separate out what is that organism, the host, and a potential pathogen. So we can quickly realize pathogens in their entirety in a sample without actually knowing what it is first. Mm-hmm. That's a really cool tool. So we've been using this technology for some time. I think what was cool is that prior to this coronavirus outbreak, together in partnership with CZI and the Bill and Melinda Gates Foundation, we set up this computational pipeline called IDSeq, because while the price of sequencing has gotten cheap, and you can place these in different countries, the compute has not. Actually, the compute problem has become more profound because intuitively you can figure this out. The database just gets bigger the more you sequence. The more the database gets large, the more search you have to do. The more search, the more compute. So while you could have a country like Cambodia or Bangladesh get a sequencer, they actually couldn't process the data. So that's where CZI and Bill and Melinda Gates are really stepping in. We have this pipeline called IDSeq, where our partners in places like Cambodia can use that pipeline to process their own sequencing data in country. And that's exactly what happened when the first index case with COVID-19 appeared in Cambodia.
Yep.
Our team there was able to, taking a sample from the Pasteur Institute, which was positive for coronavirus, able to take that sample, sequence it in an unbiased fashion, and recover literally the whole genome of the virus. Why is that important? It's important for knowing exactly where this virus is in the chain of infections, because small little mutations pop up in these viruses that give you a clue of like how far it is out from the original point source.
Yeah, it's basically like a family tree.
Exactly.
Of like who has which branch.
Yeah. It's a sad family tree.
Yeah, it's a very sad family tree.
Yes. And so we would, together with Bill and Melinda Gates, have now stood up several of these sites around the world, including Bangladesh, Cambodia, South Africa, and many other places. And the whole idea was to have regional testing centers that would be able to surveil for novel emerging pathogens as they occur in an unbiased way. And right as we're setting up this network, COVID-19 happens.
Yeah. I mean, I think this is an interesting example of a broader area. I mean, the cell-free DNA area that... What's up?
It's really about next-gen sequencing.
What do you mean?
So there's different ways of preparing nucleic acid. In this case, we're working with an RNA virus, so there's actually no DNA. But there are different ways to isolate sample, like a nucleic acid from samples. You can isolate DNA, you can isolate RNA, and there are a lot of different tricks, like cell-free DNA, to enrich for certain kinds of pathogens.
Yeah, no, I get what you're saying, but I'm just saying as a broader theme, an area that is interesting overall. There are a bunch of interesting diagnostics and tests that are happening around.
Absolutely.
So
now there's another way that the Biohub is really putting their foot forward on this. So my co-president, Steve Quake, has actually been spearheading a cell atlas of the human body, together with many other partners around the world and in the Bay Area. And one part of this is the human lung cell atlas, to understand all the cell types in the lung. And what Steve and his colleague Mark Krasnow and others, in collaboration with the Gates Foundation, have been noticing in the data is it appears that certain cell types may be more differentially affected by this coronavirus than others. And those cell types might have really important functions that might be addressed in the future in some therapeutic modality. And so this sort of basic science that when you started it, you didn't even know it would have application, has now potentially become very useful. And so this is the kind of basic science that can become applied very rapidly.
Margaret has a question. Do you think they will ever find a cure for this? And if so, how soon? What are the steps to...
Well, I mean, it's
we're a
related
couple steps
to the
back, right?
Mm-hmm.
So, walk us forward from what you guys are doing now.
Yeah, well, there's a couple ways. There's more than a couple ways. There's hundreds of ways to go about finding a cure.
Yeah.
So one is basic science, like the project I just described with the Human Lung Cell Atlas, and understanding the basic mechanisms of the virus and attacking it from that point of view. The other is what I think the pharmaceutical industry has been more akin to, which is growing the virus and throwing millions of different drugs at it to see what works.
Drugs that we already have.
Yeah, drugs that we already have, or maybe in development.
Mm-hmm.
And the idea is to see, is there some molecule that we already have in our arsenal that might work today? So Gilead has a drug that they're repurposing for this purposes. An old drug for malaria called chloroquine is being repurposed and is in many clinical trials right now. And it's that kind of drug screening modality that may bring what we call a small molecule or a pill to bear on this in a very fast way. But there's no crystal ball. You're not guaranteed of a perfect result there. However, I have confidence that there will be so-called inhibitors found soon. On the vaccine side, which is on the prevention side rather than the treatment side, it's hard to say. Vaccines are, of course, the best way to really protect a population from a virus like this. I mean, that's the lessons learned in measles and polio and many other things. Vaccines are very difficult to develop. Now, there are many new technologies on the horizon that are being developed, including RNA vaccines, many things. There are many institutions across the world working on this. And so I have a lot of enthusiasm and hope that there will be a vaccine, but there's no saying when.
Yeah.
Well, and Dr. Fauci at the National Centers for Infectious Disease and Allergy, and he gave a kind of minimum timeline that there are all the phases that a test has to go through where they might have a candidate for a vaccine that is ready to do the first phase of trials in a month or so, but then the first phase is just making sure that the vaccine is safe. It's not even testing the effectiveness of it.
That's right.
It's just making sure that the people who get it don't suffer other negative effects. And then, so we're probably looking at a year or at a minimum, right, out for the vaccine.
I mean, it would be safe to assume that kind of timeline, yes.
Yeah.
And that would be incredibly fast.
That would still be incredibly fast.
But you're basically outlining the different strategies for approaching this. There's upfront prevention, which is you work on a vaccine, and then there's after the fact mitigating symptoms. So if the most dangerous symptoms of this are basically lung damage and
Yes.
failure,
Yes.
working on things that can mitigate those symptoms so that they're less severe on the body is a big deal. And that's where the work that you were talking about with the cell atlas, which we've always kind of approached as this basic building block. It was really surprising to me when we first got into this work that there is no catalog of all of the different cell types in the human body and all of the different states that they can be in. I think it just at a very high level, you can kind of think about this almost as like when you take an intro chemistry course, the first thing that you see is like the periodic table of elements, and it's like, all right, here are all the basic building blocks of chemistry, and here's the different states that they can be in. We don't really have that for biology. So going and doing that work has been a really big project across the world that we're trying to help facilitate and build some of the software behind it as a database, ensure that different folks who are working on it can do it in a standard format and that all the data is open to everyone. But that's part of what you're talking about here is as part of the lung cell atlas, which is one piece of the overall human cell atlas. We're starting to get a clearer catalog of the different types of cells, which I think we're starting to see as giving some researchers initial leads on hypotheses that they might test for things that could mitigate some of these symptoms, like you were saying. And it's not that any of the stuff is going to be ready on an order of months, but the building blocks around this are starting to be put in place, and it's moving faster now, right? So the whole preprint area that you were talking about, the work in bioarchive, yes. Right? The scientists who mapped out the lung cells that were being used in the specific tests that you were talking about, published their preprint on bioarchive. I think it's one of the most popular recent papers. I think it's been viewed more than 6,000 times. We were discussing before, and that's just great because previously they would have had to wait, 6 months or a year to get it published formally, and we'll still go through that process. But having it so that people can kind of see that result up front is really great for that work as well.
That's absolutely right. We here at the Biohub are huge proponents of open science and open data. So not only is the paper available right away, but the data is too. And scientists all around the world can dig into the data and formulate new hypotheses. That'll really help us understand the fundamentals of disease and mechanisms of disease with an eye towards therapeutic and diagnostic development.
We have we'll take some more questions. Let's see. There are a couple of questions here, one from Jennifer and one from Nancy, around the same theme of what happens when our medical system is overwhelmed by the COVID-19 outbreak.
Well, when a medical system is overwhelmed, you simply cannot...
Let's clarify. None of us here run a medical system,
yes.
Or you're not a physician.
That's right.
So we are talking based on sort of understanding of the health system.
That's right. And I think everybody can sort of intuitively understand this.
Yeah.
You probably don't need to run a medical system to understand that there's a certain number of beds and a certain number of workers that can service patients and help them. And when the number of patients exceeds that capacity, you have to make tough decisions, no matter what. And that's a situation we just don't want to be in.
Yeah.
Yeah. And I think the concern in a lot of these cases is that if the system gets stressed, it doesn't end up just affecting people who have the coronavirus. It affects people who would be going to the hospital for other things who are now dealing with a more stressed system overall. So that again, going back to what we were talking about before, is why a lot of these tactics to slow down the spread of the virus, social distancing, encouraging people to work from home, those types of things are useful over the next period, even if they're not going to necessarily prevent everyone from being eventually exposed to the virus in some capacity. Just making sure that we can manage the load on the healthcare system is a big deal.
Yeah, and There's actually a pretty good resource called at coronavirus.gov that has the basic tips on what to do for various systems. So like check that out. I'll remind us again at the end, but coronavirus.gov. I spent some time on it yesterday and it was helpful.
Yeah, that's great. That's a great point.
So there's a question from Rex around, is this spreading just by people breathing? Does a mask help?
So this coronavirus is much like other coronaviruses that we've studied before. There are many other coronaviruses that actually cause very mild disease. They're spread by droplets. So
what does that mean?
That means there's a virus in a liquid droplet. So imagine a sneeze. Sneeze has droplets. And those droplets can land on other people, they can be inhaled, or they can land on a surface. And the evidence from preprints actually that are out there now and many and prior work from other coronaviruses suggests that those viruses on surfaces from droplets may stay active for many, many hours, potentially a day. And if that's true, then one can actually put their hand on that surface. And we're all accustomed to touching our face all the time. I'm trying not to touch my face. I'm sure you all are.
It's really hard.
It's part of our social distancing is from ourselves. And that can lead to infection. So masks, for example, can serve a couple different purposes. One, I'm not advocating that everybody wear a mask all the time. That's really not necessary. However, for example, a patient in a hospital can put on a mask, and that'll prevent spread of droplets from a patient. If you're in a very crowded situation and you don't feel that you can't stop yourself from touching your face, a simple surgical mask or mask can prevent you from putting your hand on your face.
But the most important thing is actually not putting your hands on your face.
And keeping clean and washing hands and preventing yourself from getting into situations with very large numbers of people.
Yeah. But just to be very clear, droplets don't come just from breathing.
No.
There has to be a sneeze or a cough
That's right.
to actually get the droplet and the virus to be shared that way.
Yeah, to the best of our understanding, droplets are really the way they go. How long a droplet can stay in the air and so on is affected by many different parameters, but droplets tend to go out and drop down.
Yeah.
All right, so we'll take some more questions from this. There's a question, Michael has a question of how are you taking a stand on COVID-19 misinformation? I guess this is more of a Facebook question. We're taking a pretty hard line on this. And the basic principle that we have is that we don't want content in our system that's going to put people in imminent danger, right? So, just like, in the American tradition around free expression, you can say a wide variety of things, but you can't yell fire in a crowded theater because it puts people in imminent danger. We also draw a distinction between content, whether it's going to incite violence or promote terrorism or promote danger in some way. A lot of health misinformation fits into the category of potentially putting people into imminent danger. If people are spreading hoaxes that are encouraging people to not seek treatment, if they have certain symptoms, or are promoting false cures, some of which might prevent people from getting a real cure, some of which themselves are dangerous. And we see there's certain hoaxes like if you want to cure X disease, think about drinking bleach or something like that, which obviously is extremely dangerous. If you do that, you will put yourself in harm. So that's the kind of content that we're going to go out of our way to make sure that we take down. The other thing that I think makes health misinformation a somewhat different topic that it's easier to take a hard stand on is that there are trusted authorities on this who can be a basis that are generally universally trusted for providing accurate information. So part of our partnership with the WHO is understanding what they've seen as the different hoaxes that are out there, that we can then go train AI systems and our team of we have more than 30,000 people doing content review when there are pieces of content that we think are potentially problematic, and so that we can do a good job of getting that stuff down from the system. We've also put in place a number of other policies around preventing certain kind of ads around things like this, limiting the spread and recommendation of groups around certain types of topics around health information. So this is an area where we're doing a lot, and I think that this is fully consistent with our policy of trying to give people as much voice as possible, and in trying to defend as wide of a definition of free expression as possible. And it just goes back to the example that I was talking about before, where even in American tradition, which is as protective of this as possible, you can't it's not tolerated to have speech that will imminently put people in physical danger.
Renee had a question about being a carrier of a virus. If it's going to spread, is everyone eventually going to be a carrier of the virus? What will it mean in the long term?
Okay, so let me be clear. This is a kind of virus that once you clear from your system, that once your immune system has a chance to attack it and defend your body against it, it will completely remove that virus from your body. You won't be a carrier.
Yep.
There are no carriers of this virus, to the best of our knowledge. Most respiratory viruses are like this. Your immune system fights it, and you're done. Now, and you'll have antibodies, likely, for the rest of your life that will help you fight any other variants of this virus as well. In fact, that's an area that the Biohub is also looking at very closely, is how do we understand the immune response to this virus? Well, we're actively making proteins from the virus that they can be used in diagnostic assays to see who made antibodies to it, to look back in time, to understand retrospectively who's been exposed to it. Furthermore, the Biohub and many of our colleagues and collaborators around the world are also actively looking for antibodies that will be protective.
Yep.
Antibodies themselves might actually end up being a drug in an acute setting.
Yeah.
Right.
Or,
so is there a strategy where you can take antibodies from people who have been exposed and potentially use them in other people?
essentially, what happens is you isolate the cells that make those antibodies, and you look for cells that are making particularly good antibodies that can be so-called broadly neutralizing. That is, they can stop the virus in its tracks. And that antibody can then be cloned and then mass-produced. And so that is one strategy that many folks are looking at. Another strategy is to say, well, what is that antibody binding? Can we take the thing that it's binding in the virus, the immunogen is what we call it, and use that as a vaccine? Can we make other people make those same antibodies? So that's it feeds into another vaccine strategy. All these things really weren't in play, 15 years ago. This is new technology, and I think we can expect to see things move much faster.
But I think what it's important for people to know is once someone has recovered from coronavirus, they are no longer a risk.
That's right.
As far as we know, they're not going to continue to spread, and they are not any more dangerous than someone without coronavirus
and
once they have recovered.
Yeah, that's right. And to the best of our knowledge, you can't get it again either.
Yeah. Okay, so last question. What else can I be doing to protect myself, my loved ones from getting coronavirus, especially if I have a job where I can't avoid contact with the public?
Well, it's a great question. I think we need to be cognizant of who the vulnerable populations are. When you're thinking about protecting your loved ones, if you have grandparents or people that are, let's say over 65, 70, those people are particularly vulnerable, as we discussed earlier. And so limiting visitation or limiting contact with those people or taking extra precautions just to keep them safe, because their immune systems aren't going to be as strong as someone in their 30s or 20s or in their teens. And we know they're vulnerable. So I would say, in thinking about your family and your surroundings, take extra care for those who have vulnerabilities.
All right. Is there anything else that we wanted to cover in terms of work that we're doing at the Biohub or at the Chan Zuckerberg Initiative overall? I mean, it's and we talked about testing, and we talked about IDSeq and the work there. We talked about the Cell Atlas and how that could facilitate. Yeah, we talked about bioarchive and open science. And those are a number of the strategies that we have in place. I think that's...
Yeah, and that's work that we're doing before and we'll continue doing. And the real goal is to improve the scientific infrastructure so that we are increasingly prepared to learn and discover and take care of our communities. But I think the message I think we want everyone to walk away from this is the scientific community is working as fast as they can. And what each one of us can do is actually contribute to bringing down the peak of coronavirus, flattening the peak, and social distancing. And where you can learn more, go to coronavirus.gov. That's a responsibility each one of us has to actually taking care of our broader community.
Yeah, and maybe just before we sign off, just a note of thanks to all the people out there who are working on this. I mean, I know this is a really stressful period for people who are on the front lines, nurses, health workers, doctors, researchers who are kind of putting themselves in the way of this around the world. This is really important work, and we're really grateful and want to do what we can to support you.
Thanks, guys.
All right.
Thank
Thanks,
you.
Joe.
Take care.
All right.
Thanks.
See ya.